Good morning, Toni Appelberg-Parks here, your risk adjustment CDI educator. I want to talk today about something that I get asked quite a bit about the details on, just the breakdown. I mean, we understand the acronym, but what does it actually mean? First, I'd like to welcome you back to the channel Help for Docs. If you do find any of our content helpful, I hope that you'll subscribe and share. Um, so first, if you've spent any time in outpatient CDI, risk adjustment, or HCC coding, you've definitely heard, I mean, most likely anyway, heard the acronym MEET more times than you can count. And that acronym stands for Monitor, Evaluate, Assess, Treat, or sometimes we say Monitor, Evaluate, Assess, or Address, and Treat. Most coders and CDI specialists can recite that definition without even thinking about it. So here's the problem. Knowing the definition, knowing the acronym, and applying it correctly under real audit pressure are two different things, right? So in this training, what I'd like to do is walk through the single most common MEET documentation mistakes I see in chart after chart, and the one that's quietly failing audits even when everyone involved believes they did everything right. So we're going to break down what MEET actually requires and look at some real examples of documentation that passes and documentation that only appears like it passes. It looks like it passes, but maybe it doesn't. And I'll give you a simple habit you can start using on all of your charts today that should help. So let's go ahead and get into it. Okay, so we'll start out with a chart that on the surface looks completely fine. The provider note says diabetes stable, continue current medications. That's it. It's the whole documentation for that condition at this visit. So the coder sees diabetes sitting on the problem list, sees this note acknowledging it, and assigns the HCC. On the surface, that looks reasonable. It looks like a defensible coding decision. And honestly, this exact pattern happens thousands of times a day across, thousands, hundreds of thousands of outpatient practices. And it's not that it's sloppy work, and it's not that it's a rookie mistake. Experienced coders do this every single day and genuinely believe that they're coding correctly, and I can see why. But then, months later, a RADV auditor pulls this exact chart as part of a sample, and the diagnosis gets deleted from the claim. Now, why? It's because diabetes stable, continue current medications doesn't actually tell an auditor anything about what happened at today's visit. It doesn't show that the provider evaluated the condition today. It doesn't show monitoring. It doesn't show an active assessment. It's a status update, not MEET evidence. So today we're going to unpack exactly why this happens, and more importantly, how you can catch it hopefully before the auditor does. But first we should start with a quick little refresher because we're going to need to understand this vocabulary for the rest of the training. So again, MEET stands for Monitor, Evaluate, Assess, and Treat. So monitor means that the provider is tracking the condition's status, like labs, vitals, symptoms, whether it's progressing or regressing. Evaluate means that the provider reviewed something, maybe some test results or exam findings, or how the patient is responding to the treatment, maybe even the consultation notes from a specialist. Okay? Assess means that the provider actually formed and documented their clinical judgment. Is the condition stable, worsening, or well controlled? And of course, that stable, worsening, or well-controlled is based on other parts, right? And treat means there's an active management action, a care plan, a medication, a procedure, a referral, a therapy adjustment, something. What are they doing about it? And then one important note here. So MEET is not itself an official ICD-10 CM coding rule, and it's not written into the official guidelines, but it's an industry standard framework that emerged from CDI and coding practice. But please don't mistake this. Make no mistake. It is the standard that nearly every Medicare Advantage plan and every RADV auditor applies when they're deciding whether a diagnosis on a claim is actually supported. So even though it's not official in a regulatory sense, treat it as if your reimbursement depends on it, because it does. It's just the bones, the framework of how to document. Okay, so here's the mistake. Let me restate this. A condition sitting on the problem list is not by itself documentation that the provider addressed this problem at today's visit. Problem lists are often auto-populated. They carry forward from prior visits, from templates, sometimes from years-old entries that nobody has touched. And they're frequently not reviewed or updated during the encounter at all. But this is a whole other discussion on cleaning up and organizing problem lists and the importance of that. We'll do that one of these days. But for a diagnosis to be supportable, it has to be addressed in the note for this encounter, not just sitting somewhere in the chart. So that's true whether your organization uses MEET or the related framework some organizations use is called TAMPER. Maybe you've heard that instead. TAMPER stands for Treatment, Assessment, Monitor, Plan, Evaluate, Referral. It's a different acronym, but it has the same underlying principle. So this isn't just my opinion. ACDIS has stated this directly in published guidance. Do not code off the problem list unless it is specifically addressed in the note. And that's about as clear as industry guidance gets. So when we go back to that diabetes example from a few slides ago, diabetes stable, can continue current medications. The problem here is that this sentence could be describing a chart nobody actually reviewed. It doesn't prove that today's encounter addressed diabetes with any clinical substance. Okay, so let's look at a good one and a bad one side by side. Sometimes seeing the difference next to each other helps it to click a little better in our minds, right? So on the left, we have the note that basically fails the audit. Diabetes stable, continue current medications. There's no metric here. There's no A1C value, no blood pressure, no exam finding. There's no evidence that the provider actually reviewed anything specific to diabetes today. So this sentence could describe a chart nobody actually looked at. On the right, this note would pass for the exact same diagnosis. A1C today is 7.2, down from 7.8 3 months ago. Patient reports good medication compliance, no hypoglycemic episodes, continue metformin, 1,000 milligrams twice daily. So look what's actually happening in that second note. We can tell that the provider reviewed this condition with the patient. We have monitor the A1C trend from 7.8 to 7.2. We have evaluate the compliance and symptom review, checking for hypoglycemic episodes. And we have treat, the explicit decision to continue the metformin at a specific dose. So it's the same diagnosis, same clinical situation, arguably, but one of these notes will survive a RADV audit and one will not. The difference isn't in the provider's clinical judgment. It's just whether that judgment actually made it onto the page. And in the first one, it wasn't documented, so it didn't happen, right? We want it to be readable in a way that a RADV reviewer can see it clearly. Okay, so this is one of the questions I get asked a lot. How many of the 4 meat elements do I actually need to support a diagnosis? And the answer to that is just one. One clearly documented meat element, monitor, evaluate, assess, or treat, is technically sufficient to support a diagnosis for that encounter. This is confirmed consistently across industry sources, including Actis, Rapid, and the Solventum, formerly 3M HIM guidance. But here's kind of a nuance that matters with that. One element is the floor, right? It's not the goal. It's just kind of the legal minimum per se, not the safe target. So if your documentation only ever hits exactly one element, you have zero margin for error. One ambiguous phrase, one auditor who reads a note slightly differently than you did or you intended, and that diagnosis is gone. So a more realistic approach or defensible target is 2 to 3 well-documented elements per chronic condition per visit. And that will give you a real cushion. If an auditor disputes whether one element counts, you still have some backup evidence sitting right there in the same note, right? So the rule isn't the bare minimum is fine. The rule is know what the bare minimum is and then build in some margin above it. So let's look at it again, letter by letter, starting with M for monitor. Monitor means that the provider is documenting that they're tracking the condition status over time. Is it improving, worsening, or holding steady since the last visit? So what this looks like in a real chart, it could be lab or vital trends, an A1C, maybe looking at the last 3 A1Cs, a blood pressure reading, an INR, a weight. It can also be a symptom review tied specifically to the condition, or some explicit language about progression or regression. A strong example would be something like blood pressure log reviewed, averaging 138/86 over the past month, improved from last visit. So notice this isn't just a number. It puts the number in context, showing that the provider is actually looking at the trend over time. Next one is E for evaluate. Evaluate means that the provider reviewed something concrete. Maybe test results, imaging, exam findings, or how the patient is responding to treatment. So something, qualitative. In a real chart, this looks like labs or imaging that were ordered or reviewed, maybe physical exam findings tied to the condition, or a note about some medication effectiveness or treatment response. So a strong example of this would be reviewed today's lipid panel. LDL improved to 92 on current statin dose. That single sentence shows that the provider engaged with a specific data point and connected it to the patient's treatment. Next one, A for assess. So this is the one that coders miss the most often because it requires the provider to actually form and state a clinical judgment, not just mentioning the condition. The diagnosis needs to appear in the assessment or plan section, not buried in like a history field or a problem list. So what it looks like, severity or stability language, like well-controlled, worsening, stable. The diagnosis named directly in the assessment and plan, or clinical reasoning that connects findings to the diagnosis. So a strong example would be type 2 diabetes, well controlled on current regimen, no evidence of nephropathy. That's a provider actively thinking through the condition. They're not just restating the existence of the condition. And last but not least, we have T for treat. Treat is usually the easiest element for coders to find because it's the most concrete. It's like a medication, a procedure, a referral, a therapy, or maybe counseling that addresses the condition. In a chart, this would look like maybe medication started, adjusted, or continued, a procedure or referral ordered, maybe documented counseling or lifestyle intervention. So a strong example of this would be continue metformin 1,000 milligrams twice a day, referred to podiatry for a diabetic foot exam. So you have two treatment actions in one sentence, a medication continuation and a referral. So they're both clearly tied to the diabetes diagnosis. So put those four together: monitor, evaluate, assess, treat. And now you have a complete picture of active management. And remember, you only need one, but now you can see why hitting 2 or 3 will give you that real protection. So I want to clarify why this specific mistake is so important, why it matters so much right now. And that's because meat is exactly what RADV auditors are checking for. Every chronic condition reported on a Medicare Advantage claim needs chart evidence that survives this exact test. And unfortunately, audit activity is not slowing down. CMS has actually confirmed that it's accelerating their RADV audits, moving towards roughly quarterly audit cadence that touches nearly every eligible Medicare Advantage contract. So the sample sizes run anywhere from 35 to 200 enrollees per contract, and these audits are proceeding even while some of the extrapolation methodology is still working its way through the courts. But here's the part that I really want you to sit with. Records most often fail for documentation gaps, not because the provider's clinical judgment was wrong. Missing meat evidence is one of the most common and most preventable failure points that auditors find. So in my mind, it's just quite sad when the provider has done everything right and it still gets clawed back. And it's all because of documentation. You did it, you just didn't document it, right? So, in other words, a diagnosis without a meat-supported encounter note is, in an auditor's eyes, a deletion waiting to happen. It's not because the patient didn't have the condition. It's because the chart didn't prove that it was addressed. And so with that, I want to cover a habit that really matters more in 2026 than it ever has. And here it is. One question that you can start using on your very next chart. Ask yourself, if I remove the problem list from this chart, would I still know the patient has this condition based on today's note alone? So the note should stand alone. If the answer is yes, you have meat evidence. Code it with confidence, you've done the work correctly. But if the answer is no, that's your signal. There's no meat evidence yet. And this is exactly the moment that a coder should query the provider, or the provider should use it as a litmus test to confirm that they have provided the needed documentation. For coders, you need to use a clear, non-leading question that asks them to clarify the status, the treatment, or clinical significance without suggesting the specific diagnosis. So I'd encourage you to build this single question into your chart review workflow or your provider education for our coders and educators out there, and just as a self question to yourself, providers, when you're documenting. It will protect coders from assigning unsupportable HCCs or providers if you're doing your own coding, and it protects providers from documentation habits that will put your charts at an audit risk. So it's one simple filter applied consistently, and it prevents that scenario that we started with. Okay, so as we wrap it up, let's kind of pull it all together into the 4 things I want you to take away with you. First one, MEET stands for Monitor, Evaluate, Assess, Treat. And even though it's an industry framework rather than an official coding rule, it is the standard that nearly every RADV auditor applies. I believe that is how they train the auditors with MEET. The second is that a condition sitting on the problem list is not by itself MEET evidence. It has to be addressed in today's note to count. And if you've seen some of the problem lists out there and how conflicting and jumbled they are, you can see why this is so. And third one, only one MEET element is technically required to support a diagnosis, but I recommend 2 to 3 elements to make sure you have some real meaningful documentation that's going to protect you in an audit. Just a cushion, you know. And number 4, run the problem list test on every chronic condition in all your charts. So would this note stand on its own without a problem list, without the problem list? And will it still tell you that the patient has this condition and that the condition was addressed? So it's one habit that's applied consistently and could be the difference between documentation that looks fine and isn't, and documentation that will actually survive in the case of an audit, okay? So that's why. Okay, and that's a wrap. We are at the end of this training. Just one final recap. MEET is only as strong as the note written for today's visit, not what's carried on the problem list from 6 visits ago. If your practice or organization needs help building stronger CDI workflows, preparing for RADV audit readiness, or training your providers on documentation that actually holds up, that's exactly what we do at Help for Docs, and you can find outpatient CDI support, HCC risk adjustment auditing, and physician education resources at helpfordocs.com. And I want to thank you so much for watching. If you do find any value in these trainings, I hope that you'll subscribe so I can keep bringing them to you, so we can get them disseminated out in the healthcare industry and just do better overall. So if you'll subscribe, and of course a like is always a benefit too, and it lets me know that you like the content and I should make more like that. So thanks so much for watching, and I'll see you in the next training. And by the way, one last thing, here's the sources that I consulted and checked in preparing this training. So they're here if you want to dig in a little bit further. Thank you, everybody. See you next time.